Okay.
Okay, guys, so we're going to talk about spinal that we're going to start doing here shortly. And a few issues about recovery room in general, of what I've watched over the last few months. I've been here, things that most of you know very well, and some of you are a bit newer here, to the camera. So spinal anesthesia, first of all, why are we going to do it here? It's overall, if you start doing it at 6:45 here, and compared to about 7:15 there, they will save you about half an hour of time. Time that it's better used before than if you would have to wait at the end of the day in recovery and physical therapy. So that's one reason. The other reason, you don't really want to be in the room with a joint moving around the patient, front, back, too many people. Somebody has to hold the patient in front, somebody does the anesthetic. There's a lot of movement. So unless you have a huge room, which you guys have a decent sized room, but not the biggest that I've seen, it's a chance of contaminating stuff, so we don't want to do that. And in the future, if other places do that already, do 2-3 knees a day, you really save a lot of time by doing them here and moving them to the OR. So let's move to the next slide. The next two slides is nothing for you necessarily to understand except for two things. Number one, spinal is not an epidural. In epidural, you use a lot of local anesthesia, about 20 to 30 cc's of local. So there could be potential for more complications there from an epidural, because if those 30 cc's of local would go spinal and not epidural, then you can have a total spinal cardiac arrest and things like that. In spinal, we're talking about 2 or 3 cc's of local anesthetic. You won't get a local anesthetic systemic toxicity with it. You're really not going to get a total spinal cardiac arrest. If it happens, it's extremely, extremely rare. We have a few slides about this here. And if it happens, it's more because of patient's conditions than your spinal if you do it at the low level that we're going to do. And next slide is another diagram of where actually we do this. We do this very low. At L4-5 or L3-4, there is no spinal cord there. It's only coda equina. So when you put the needle in, you're really not going to hit the spinal cord. When people tell you're afraid because my spine is so-and-so and you hit my nerves, you don't really need hit the spinal cord ever. You don't actually hit the coda equina either, but that's what you have. There's a lot of empty space with a lot of with CSF. So spinal, you get CSF injected 2 or 3 cc's. Epidural, you don't want to get CSF. You want to stop in front of that and inject 20-30 cc's. We're not going to do epidurals here. All they're going to be are spinals. 2-3 cc's of local once you get CSF. The other reason I show you this is because of the positioning. I'll actually have a volunteer when it's time to position the patient here on how we're going to do it for most of the cases. We need to open the spaces between the spinous processes in the back so I can get the needle in easy. Now, young and healthy patients is not a problem. Our patients are not going to be young nor healthy. Their back is going to be pretty hard, and getting in between two spinous processes sometimes it's not going to be easy. Next slide. The one that everybody kind of wanted is the dermatomes. It's nothing complicated here. If you look on the right side of it, you'll see that T10 is the umbilicus, T6 is the xiphoid, T4 are the nipples. So we might not even have time to check a level here once you do the spinal, because hopefully we do it about 6:45, 6:50, and then we go to the OR. So usually it's going to take up 2, 3, 4, 5 minutes to onset for a spinal. If we have more than that, we probably should check a level to see how it progresses. Most of the spinals we're going to do here are not going to be T6, T4 level. We're not going to do C-sections here unless somebody decides to come and deliver here. Beth? But if they don't, we're going to stay with the low spinal at L3, 4, L5. That should get you a T10, T12, L1 level. That's plenty for a total knee. Unlikely to go higher than that. If we have time, we'll do a check. We'll do a dermatomal check once we're done. But most likely, spinal is in, we'll do a block, and then I go to the OR. That is how I think things will go, especially for a 7 o'clock case. With the surgeon being on time, there's really no reason to be here for half an hour. Sometimes we wait at the blocks for a while. I don't see that happening with the spinals. The clock is ticking the moment you put the spinal in. My plan is to have a spinal that has about 2.5 hours of anesthesia. That's going to be followed by a couple of hours of recovery. So I think about for a 7 o'clock case, by 1 o'clock we should be able to have physical therapy or so here. We'll see how the first few go, and we adapt the anesthetic if needed. If they're faster in the OR or slower, we'll change it. If we're spending too much time here, I'll bring you dinner.
All right.
I ain't gonna stay. I'll just bring you dinner and leave.
That was good.
Yeah,
That wasn't your fault. Right.
Okay, equipment. What do we need for this? We already have a cart. We're gonna use that. We're gonna change it a bit in the sense we're gonna add a few spinal kits in there at the bottom, to the right probably, and a couple of needles, a 20 and a 22 gauge spinal needle. I think we have 22s.
Oh yeah, we have both.
If we have both, they're 3.5 inch. What we should have is a 3.5, 20, and 22 gauge.
She ordered them. I don't know if they got here yet.
Okay, so we will have, the spinal kit has everything in it, if you want to use that. The issue with the needle is a 24 or 25 gauge needle, which works perfectly in young, healthy patients with a normal back. As you age, everything gets much harder in the back there. It's very hard to go with a small needle. So instead of wasting 10, 15 minutes and then changing to a bigger needle, we go from the beginning with a bigger needle. For me, everybody's about 60, I go with a bigger needle. Why not bigger needle in everybody? Because there's a chance of a post-dural puncture headache. The bigger the hole in the dura, the higher the chance of CSF leaking out of there and giving you a headache that you're gonna hear about probably the next day when you call them. We'll get to that. So pretty much everybody under 60, 65 will try to use the needle in the kit. Above that, we'll use one of the bigger needles, 20 or 22, depending on how the patients look. What else do we need? We need local anesthetic. The kits will come with local anesthetic. I personally do not use that. It's heavy bupivacaine. It gives you more hemodynamic instability, which you don't really want here. I'm going to use 0.5 BP, the one that says not for spinal. Cross that. Now, that's been used for decades for spinal anesthesia. The only reason it says not for spinal is because FDA was not tested by the company, so FDA, they cannot write that. They have to write that on it. It's not been tested. Why? Because the medication is extremely cheap. To test it and get it to the FDA approval would be extremely expensive, and no company wants to do that. But it's been used for decades for spinal anesthetic. It's preservative-free in normal saline or water. So we're going to use at most 3 cc's. We might start the first few with 3 cc's. That will give you about 3 hours of anesthesia and a few hours to recover. If I see that it's too much, we're going to cut it down to 2.5 cc's. We'll take 1 vial from there. We're going to discard the rest to 7 cc's. That's hopefully we're not going to end up with 50 cc vials of 0.5 like we have a 0.25. So if we keep it at 10, that's good. What else do we have here? Everything else we pretty much have. We use midazolam for blocks. We're going to use midazolam for spinal. I don't want to use much more sedation for 2 reasons. One, I don't think they need, and second, if you sedate them more and they're sitting, you will have to really hold them. They start moving left, right, forward, backwards, and they will be sitting. It's not just in bed there. The emergency kit, we already have intubation equipment there. We don't have to add anything to that. It's already there. Drugs. The drugs here are for the rare instances that I'm going to discuss a bit later, but pretty much ephedrine, phenylephrine, atropine, glycol, epinephrine, IV fluids. And just know where the crash cart is.
You want extra gloves too?
We're going to use sterile gloves this time for spinal. If they fit in the cart, fine. If not, we can find a place. I use 7, 7.5. 7.5 would be good, but there'll be other people here that probably use less. So if they don't fit in the cart, we'll just give them something. But there will be sterile gloves for this. It has to be sterile. Any questions up to now? Next. Before spinal. Consent, you already get. I don't think we need anything different in the consent. It's an anesthetic consent. You just get it. We might just have to tell them this is a spinal. It's not generally going to be on the spinal, numb from the belly button down with some sedation. That's the only difference. Timeout, we already do timeout, so it continues. We should give them 500 to a liter of fluids before the spinal is in to prevent hypotension. Now, we don't want to give much more than that for 2 reasons at least. One, Many of our patients are not healthy. Their hearts might not be fantastic. Might have COPD, emphysema. Hopefully we're not going to get those patients here, but we'll see. And second is urinary retention. You will have urinary retention with spinal anesthetic more than with other anesthetics. The more fluids you give before, the higher the chance, at least theoretical, to get urinary retention. So compromise would be somewhere about 500 cc's. We'll just start the IV, let it run, and by the time we get here, we should have 500 in. Question?
Maybe.
Yes.
Maybe.
Maybe. Well,
You know, if they don't come back here till like 6:20, we're gonna have to get them in
Yeah,
again, so they can get
they're
their
gonna be
IVs started
priority.
at the closer
Right, I
to
was
6
gonna say,
instead of 6:30. Because sometimes that's the last thing we
Can
do
we
before
come
we
like
bring
at
them over.
5:50 and open the window and start getting them going, so we can have them back here for 6?
Yeah, I mean, we just have to make sure, cause I don't think the ladies downstairs get here to do the screenings until then, so we have to make sure
Oh, yeah.
that they get
I
screened.
come early, they wait here before me.
Yeah, they come
yeah.
early.
Right, so then, yeah, we can get them to come up with.
no, it's not a must. Ideally, we should have 500 cc, but if we have a 350, 400, that's fine. I'm not going to stay there and wait for another 100. We can go ahead and proceed. It's better than no fluids. Some fluid is better than no
Yeah,
fluids.
just leave it open.
Leave it open. Just pretty much leave it
While we're
open.
on the subject of consent, for Monday and Tuesday, are we really supposed to be getting surgery consent signed? No? Okay, so the
What about the
doctors need to know
anesthesia
that.
consent?
Now, the only thing, no, those, so what you can ask the patient is if they did have consent in the office, like if they know what they're doing, they know who their doctor is, they discuss it, and they have no questions, then you can get them to sign it in here. But if they have any questions at all, they cannot sign the consent. But if you confirm with them that they've been verbally consented, then they can sign.
Okay.
But if you can't confirm that they've been verbally consented, then they have to wait till the physician puts this on.
We also told Dr. Hildebrand today that he's gonna have to go back to the OE and do things.
Yeah. Yeah, he and I had that discussion too, but we'll see.
Alright, moving on.
We have to
Thanks,
focus
Nicole.
on
So then monitoring is the same, blood pressure, EKG this time, for real. And pulse ox, I guess somebody wants pulse ox. All of them are important, so we're gonna do ASA standard monitoring. Oxygen, nasal cannula, use the one with CO2 because this will be used in the OR. And then we need the blood pressure as a baseline, which you already take it over there, so we need one to see kind of where the blood pressure goes afterwards, after spinal. Spinal, switch to the picture. I forgot to tell you when to move. We are here.
Yeah, that's right.
Yeah, can somebody just wants to volunteer on a chair here? I mean on a bed. So we'll be sitting, legs here, back there, feet down. Put the binders in whenever you guys want to put them on before when they're flat or when they sit like this, you're gonna give them a pillow, we hug it. We're gonna give them a chair, ideally one that doesn't have wheels to relax the legs. I think we have one, right?
Yeah, we
And
have
then-
some in pre-op too.
And then we'll have the spinal kit set up here. And we're gonna put the bed up and ask them to relax their shoulders and arch their back towards me. Angry cat, whatever. We ask them to push the back out. And we can sedate them whenever you feel like, before or now, 1 or 2%.
Or the
And
bed's
that's it.
supposed to be high, huh?
And the bed will be high, yeah. You want this because as high as we need. You want this because you want the back to be as open as possible for the spaces to open to make it easier for me. So shoulders down, this arch pushed out, and hug this monitors. We start the blood pressure every 3 minutes here. Pulse ox EKG is gonna be missed. The EKG might not work. I wouldn't worry about it as we do it. We have the spinal kit here. We do it, and then we put the patients flat as soon as we're done. The local I'm using. Thank you, ma'am. You can return to it. Now, when we're done, depending on the local anesthetic, some people keep the patients in a certain position Others move them immediately flat. This is a local anesthetic that is isotonic, meaning it's gonna sit where you put it. So it doesn't matter what we do. If we change anesthetic in the future, then we might address that. But right now, it really doesn't matter if you do it quickly or you wait a minute or two. You can do something if you have to do it and then just put it flat. Okay, so the spine. The next slide. Sitting position, legs on a chair, knee bent, hugging a pillow, we've done that. Verses 1 to 2, monitor every 3 minutes. Again, I don't think it's gonna be a long time that we have to do that. Put the patient supine, and we can do a dermatomal level check. I don't think we have to because we might not even have time to do that. If we're here for half an hour, which that would be a bad time for all of us, then we can do a dermatomal check to document. But I don't think we need to do that for any charting purpose or anything. All is the vital signs. That's it. Post-spinal. Now, the difference from spinal and the blocks is with the block, we do the block, we do the paperwork, and sometimes we leave them there, pull the curtain, we see the vitals, they're fine. Here, we need to sit there until we leave. It's an anesthetic, every 3 minutes blood pressure, and continuous EKG, and obviously pulse ox. That's the main difference. Again, hopefully it's not going to interfere with the workflow too much if we leave the place a few minutes after we spinal. What are we looking? Yes, what was the question?
If we have a first case block along with this, then we
Another box.
Another
Different
block.
You can stay there. I don't think I need 2 people there.
No?
No, I mean, we are there. I mean, unless
Yeah, we there
somehow
monitoring the two, yeah.
we'll see.
Make
But
it a point where there was
They're not, yeah, I mean, they don't have an airway or anything, so they're not one to one.
it's only that we have to stay there and see the
Somebody
blood
Yeah, you just have to watch
pressure.
and monitor, yeah.
Because
So
the blocks
set it
is a
at-
bit different. They're not gonna have hemodynamic changes as much as spinal, and hopefully this spinals won't. But we'll have to see. And it's important for documentation to do that. What to look for? Because you stay there and what? Bradycardia, hypotension, difficulty breathing, nausea, vomiting, and loss of consciousness, agitation, confusion, upper extremity weakness. Why? Bradycardia happens with the high spinal. Hypotension also with the high spinal and vasodilation. Difficulty breathing, again, high spinal, nausea, vomiting, hypotension, and all the other ones, the neurologic changes most likely come with high spinal. Not unlikely to happen, but we have to kind of be aware of them. If you notice any of that, anybody gets nauseous after spinal, it's hypotension, number 1, and high spinal. So fluids, and we'll talk about it. Next slide, this is complications like this. I highlighted the ones that you might be involved in. So in the recovery holding here, you'll be involved in nausea, vomiting, hypotension, maybe. When you see them in recovery room afterwards, you're about to discharge, is urinary retention. That might be the one that might affect you. The next day, when you call them, it's going to be post-dural puncture headache, and hopefully never ever spinal or epidural hematoma, which here it's on the vertebral canal hematoma. Hopefully never, because that's a big deal. That's the worst thing that can happen, in the sense that once they get a hematoma in the back and it's not recognized quickly, they will be paralyzed unless they have an intervention within as early as 6 hours. 6 hours, they need to go to the OR. There's nothing to do. And we'll get to that. Let's start chronologic on things, how they could happen if they ever happen. It's cardiac arrest would be the one that would be the worst thing that can happen here. And that has to do with hypotension really that gets bad, hypoxia that really gets bad, and high spinal. Trendelenburg, first, put them down as much as possible. Fluids, along with epi, ephedrine, atropine, we'll decide at the time if that ever happens. Most likely, if it's that bad, obviously they need to be intubated. That's why we need the intubation kit there. Again, I'm not really seen with spinal this happening. With epidurals, it's possible. Spinals, not really. So if you see hypotension, nausea, and vomiting, mostly nausea, just Trendelenburg, let the fluids run, which we already do, and we're gonna go for some inotropes. Usually we have ephedrine, we're gonna give that quickly. We don't have it here, but we have it in here. So we're gonna go get ephedrine, mix it in 10 cc, I'm gonna start giving it. if necessary. Again, I don't think so, but we'll take it from there.
No, the veterans.
I think that's in there.
It's a narcotic.
Yeah, it's not.
Yeah, unfortunately, it's in the narcotics thing because it could be used for, sniffing and things like that. Second one is total spinal. I don't think we can get a total spinal going so low as 2 or 3 cc's of local. However, there are case reports of that because maybe anatomy is different than normal. It's very rapid. Patients stop breathing, they say, I can't feel this, I can't feel that, and all of a sudden they're out. You follow then the protocol for any cardiac arrest also. They need to be ventilated, intubated, and taken from there in terms of the vital signs, which we already set up for that. That's why we stay there. But that is quick. You do the spinal, you put them flat, and all of a sudden they're out. Flat line also, so no good.
We can skip that.
Urinary retention. Now, it will happen. How often? We'll see. You will have probably have a policy here that you already have about urinary retention or peeing before going home. I don't know if you use a scanner
We do.
or not here. So that probably will be more important here than in other patients because at least for a little while after the surgery, they won't be able to feel much. And they already got somewhere between 500 and a liter here, plus whatever my bozo colleagues are gonna do in the back there. So you could see about 2 liters of fluids in a period of 2 hours. That distension plus the spinal can give you urinary retention. So we'll take it from there when that happens. We have a policy in place for that, so we'll see how that goes.
And they also, I did ask the orthopedic guys about that, and they do have a system in place to where if the patient has trouble peeing once they get home too, they have an appointment set up with their urologist where they can go into the office and have their bladder drained and take care of that. So that way the patient doesn't have to go back to the ER or anything like that,
But
especially.
If we let them go late, then 7 hours.
They
Are
still,
we
they
making sure
have,
they urinate before they go home?
I think we.
they're not requiring it on the orders, but we're still negotiating on
My suggestion is to scan.
Yeah.
If it's empty, it's empty. If it's full and haven't peed,
Right.
take it empty.
Yeah.
Because
Just
then
do
you
a
know
body
that is.
scan before the
Yeah.
period if they don't
If they
urinate.
don't
Yeah.
urinate.
Take it from the scan. No urine, go home, urine.
Right.
Come on, you gotta pee because
Right.
it will become a problem. Post-dural puncture headache is something that you might deal with the next day when you call them. And that's something that it hurts like never hurt before. It hurts worse with movement. It's like a migraine almost headache. And it's because of the CSF leak created by the needle. We're trying to use the smallest needle possible, but at the same time we want to get a spinal in, so you might have a leak. Unlikely in old patients, and unlike it's rarely in obese patients, so we have both. But it still can happen. Obviously, if it happens, you can read through this, but the most important part is the next slide, which is what to do. Hydration, rest, caffeine, and if that doesn't work, that's a conservative treatment, is they go back to a place where they get an
Recovery
epidural patch.
disappearing.
If it does happen, when we do a post-op call, and they have a severe headache, are you gonna be bringing them back here for a blood test?
We'll have to talk.
Hold on, babe.
They have
have
interventional
Victoria
right now
LeBlanc.
with my
We have what?
probably
Victoria
around
LeBlanc.
Today?
Is that today?
Victoria
Yes.
LeBlanc.
Yeah. No,
But yeah, but that's born.
No. Walgreens in Franklin, right?
It's not there.
I called now.
Okay. It should be coming. If it's not, then the nurse did call Mel at the office, and they said that they were sending something. So your next step, if it's not there, would be to call the number on your discharge instructions, call Dr. Hildebrand's office, but it should be coming through. 625-2200. Is that what you have? No, it's a real number, babe.
Is
What's a rear monitor?
985.
When you call them and they start describing a headache like that, then obviously you let whoever's here know so we can follow them also. But tell them to rest, drink as much liquid as possible, and as much caffeinated drinks as possible. And we will probably have to call them back the next day unless they're already somehow in contact with the office. Usually they go away, but not always. And sometimes you need to get them in to do an epidural blood fetch. It's not often. We're not going to have this often. Again, this is not OB. This is not young patients with open spaces and a lot of pressure, CSF pressure. So I don't think it's going to be that often. But it could happen, so we need to be prepared to follow them and give them some instructions.
You'll do that here?
Well,
That's what we were just talking about.
we should reach that, deal with that when it
Yeah,
happens, if it happens. I don't have a problem doing it. We don't have epidural kits here. We need the protocol in place to draw blood.
We used to do it.
I know, it's fine.
We need 20 cc's of blood drawn sterilely and put in the back with an epidural kit, which we don't have. So again, we'll see. But when you call them, first thing we're gonna tell them conservative, and then the next day or later we will have a plan for epidural blood pressure somewhere. Ideally, you want to fix your problems in house. You don't want to send them somewhere else. It's not nice, but we'll see how that goes. Spinal epidural hematoma. So this is not going to happen in the day of surgery. It's not going to happen in recovery, but it could happen overnight or in the morning of. Now, if it happens, it's like a new onset, a re-onset of a spinal. So if you have a spinal, you don't feel anything, then it recovers. You go home, everything is fine. All of a sudden you start getting numb again in any of the extremity, one or two, or starting having back pain. There's a good sign that you're probably developing a little hematoma in your back. If that happens, they need to immediately go to the hospital because they need an MRI or a CT scan, and most likely they need surgery, hematoma evacuation. It can happen spontaneously in 1 in a million or so patients. It can happen on the spinal a bit more frequent, but really still rare. Or if we did not catch the anticoagulation status. If we somehow missed it and they are still anticoagulated from whatever they're taking, that could happen more often. Which means here, and in general, nobody's going to do a spinal on anybody that has any slight anticoagulation issues. They all have to be normal. Like not taking anything, or if they take something, you wait the appropriate amount of time to do a spinal, which is very different from blocks. We do blocks on anticoagulated patients without a problem. Spinal, it's a no. So if you get a call, if you call and tell them I was fine, but now all of a sudden I start getting tingly in my legs and start getting numb again, or my back hurts, you immediately tell them to go to the ER, period. Because you might have a hematoma in your back. Even if it is not true, much better, because you have a small window of opportunity to fix it before it's become a permanent injury. That's where we're gonna go with that. Just any of that. If any of us is here, just get us on the phone, talk to them, maybe get more details to maybe differentiate if it's really that or something else. But the best bet, just go to the ER or come somewhere, go somewhere to be seen immediately. Ask them when it started to see what time we lost already and how much more we might have. Okay, this is it about spinals. Again, we're gonna do them here 15 to 20 minutes before we're going to the room. Not much time for monitoring. Ideally and hopefully not too many complications. The most going to be some mild hypertension that we might not even treat, but we're going to monitor. We do a adductor canal block after that. Spinal adductor canal OR. That's the plan. Quick, 15 minutes. Some spinals are going to be long. So what I do when I'm in the OR and I do them, which is not often, I give myself 5 minutes from the moment I finish prepping. If I don't get a spinal in 5 minutes, we go to sleep, general anesthesia. Here, I'm going to look at the clock and I'm going to give myself maybe 10 to 15 minutes if we have the time. But I'm not going to torture somebody until I get it, because sometimes it's just not going to happen. And you can still do surgeries under general. It's not the ideal situation, but you have to, put a stop to your attempts. So probably be 10 minutes. I'm going to look at the clock, 10 minutes. If it's not there, I'm going to stop, adductor, back, general. And that's it. We have the card, we just need to put some spinal kits, needles, medications, we know where they are, we know the crash card is over there. We monitor, we stay there. If we have another block at the same time, I think we can manage. When I'm here, I know I'll be there and help. If I'm not here, I can talk about whoever comes by, but hopefully they'll be helping. If they don't want to do the spinals in the recovery, I think if it's just one spinal in the morning, shouldn't be a big deal, but I think we should try to let them know also that that's how we do it here. Although we never started it. Any questions about spinals? Any questions? Yes?
I have a question just about like the patients that are gonna be candidates to have total knees here. Are y'all gonna look at them on the premise of, if I have to put this patient to sleep, are they a candidate to be done in the surgery center?
So, honestly, there is no difference between health status and spinal versus general, because spinal can be as bad as general. Once you do a spinal and they become hypotensive or they have vasodilation and sympathectomy, they can behave worse than actually a general anesthetic can control maybe better. Now, except maybe the lungs, although if your spinal goes high enough, even your lungs are affected. So, no.
Okay.
No, the better outcome is from an orthopedic perspective and blood loss and things like that and DVT prophylaxis.
Okay.
But it's not going to make a difference. Oh, I'm not going to do it because he was good for spinal, but it's not good for general. No.
Okay.
They're candidates or not candidates. And mostly candidates for, are they able to do what they need to do when we're done in terms of physical therapy? Can they be discharged? Is this really the case? Not spinal versus general. Anything else?
And we do have, copies of the exclusion criteria that we can show y'all too. We'll do all that after, but there is gonna be a more strenuous selection of patients than just our normal pre-admit. So,
Do we have the spinal discharge instructions for these patients that we send them home?
So
Like what to look
They're still
for,
gonna
like
have
if they,
the spinal discharge instructions should not be anything because there is nothing left. You should have normal, you recovered your motor and sensory
like
function by the
should
time
show
that
if you develop a headache,
but I think
hydrate.
we can add to the normal instructions or make special ones. I particularly prefer to just add them to the normal discharge instructions, not to add another paper and create more paperwork. The
Just like
post-dural
we have a
puncture.
block discharge instruction.
Yeah, but to this we can add, if you develop a headache,
Do such and such.
do such and such. If you start getting numb or tingly in your legs, once everything is resolved, call back immediately. If you're feeling the day hours, or go to the ER immediately. If nobody answers, or the other way, go to the ER. But I just don't want them to go to the ER for no particular reason.
Yeah,
which-
especially with it bad like it is now.
Yeah, that and the fact the way they will be evaluated here, the surgeries in the center is a lot by readmissions or admissions to the hospital. So we don't want to create an issue that does not exist. That's going to happen extremely rare, often something.
Yeah, well,
To have a spinal hematoma, that's extremely rare, like rare. So I don't want to put too much emphasis on that, especially with the patients, that every little tingling that they feel from their previous back issues, the way they sleep at night, all of a sudden, oh, I feel tingling in one leg, I'm going to go to the ER. So I would prefer them to call if, especially, that's a possibility first. Okay, a few things here that in recovery. There are a couple of issues that we are concerned when they come here. First of all, in an ideal world, they should come in stage 1, like back to more or less normal. Now, they don't. They don't for a few reasons. One is we need to maintain a decent, efficient workflow in the OR. You can't keep them there for 10, 15 minutes until they're really awake and ready to come to recovery, because then we'll really slow down the process, and really no place does that anymore. Now, some hospitals that are slow to start with a turnover of 45 minutes to an hour, they can afford to do that. But when you do many cases with a turnover of 2, 3, 4, 5 minutes, you need to get the patients out of there so they can clean their room and do that. The compromise is that they come here in stage 2. They're not ready, and you guys have to deal with that. as CRNA or the MD will drop the patient, go and deal with the room and bring the next patient in, but you have to deal with stage 2 patients. Almost all, from what I've seen by being here. So, stage 2 means a few issues here. Airway protective reflexes. Are they ready to protect their airway from secretions or aspiration or not? Respiratory pattern. Are they breathing regularly and they sustain that on their own? They should when they come here, but not all the time, and you know that. Hemodynamic. The stage 2 is known for hypertension, tachycardia most of the time. In a healthy patient, that can last, that you can allow that to happen for a while. If they're not healthy and they're heart disease, serious pulmonary disease, if you allow that for too long, we can end up with adverse cardiac events. So that's something I will monitor here and maybe intervene rarely. Once they come out of stage 2 and they're awake, their heart rate comes down, the blood pressure comes down, saturation is fine. But there's that period of time that usually in the past they used to be in the OR monitoring that, and actually as they would wake up, we would actually give esmolol, hydralazine. We would do that over there. Now that's on you guys. Now that's, if it's right or wrong, this is what's happening pretty much everywhere. So you become a little bit of intensivist or anesthesia provider for a few minutes here or more when they wake up.
Are the patients getting clearance before? Like, are they gonna have to go to like family doctor or cardiac clearance before they have?
They're what? The needs?
Yeah.
I think they'll not
Yeah.
all.
Not
They'll
all.
follow the
I
same.
think it's part of their routine at the office
Okay.
that they have to get a clearance of some sort, whether it be primary care or cardiology, depending on who they're followed by.
At least to start, I think those patients will be healthier than our normal
Yeah,
population.
and they have a joint class that they go through at the hospital, at the office. And it also sets up, like, their home health is already set up, they should have all of their equipment at their house before they ever arrive here. All of those things are taken care of ahead of time.
Two more things that happen here. One is recovery of consciousness, which is again part of the stages, and you get them here when they're barely emerging, so they can be hyperactive, almost to the way of delirium, or hypoactive, and that's, if it's beyond 30 minutes, there's delayed emergence. And there are a couple of issues with that, and we'll talk about it. And then knowing what medication they got in order to know if you need to reverse them. And sometimes we dealt with this a couple of times here. So first one, the airway protective reflexes. What do you look for? You want to know they're back, they're ready, you can let them be. Gag reflex, spontaneous swallowing. They have stridor, that's not a good sign. Upper air obstruction. You always hold the jaw, do jaw thrust. Ideally, I would like to see you not doing that because you don't have to. But you seem like you have to do that quite often. That's another example of they're coming back in really early stage to just end of sleep, barely waking up. 80% of you guys on the patient, you do jaw thrust here. I don't like it. But there will be a process to change that. If you have to do that and the patients are not really doing anything, they are not awake, they're not protecting any airway. They're out, asleep, especially they tolerated oral airway for a while in there. So when you do this forcefully sometimes and they don't react, they're not protecting anything. They're still asleep under really anesthesia. And then the other couple of things, excessive secretions and laryngospasm. We see a few of that with the kids. Sometimes they come here under anesthesia. They are not protecting anything. They're still asleep. They have a lot of secretions, and when those secretions touch the vocal cords or any area around there is very sensitive, they immediately go into laryngospasm. That's something we need to prevent on our side over there before they come here, because you do not have positive pressure here. The treatment for laryngospasm in those kids is positive pressure. Hold it. Here you have nothing. So what do we do for that here? Again, if we still get some of those. Glyco to dry the secretions. A bit late. They should be dry from there. Atropine. Every time you have issues in laryngospasm, especially in kids, and if it's prolonged, expect bradycardia. It's gonna happen slowly. So you already give glyco for secretions, but atropine has to be right there. The moment you see the heart rate going down, atropine. Even if it's still 60, 70, it's gonna go down and then it's hard to get it back. Lidocaine helps with the reflexes, so will help. And then succinylcholine, if you can break it, because you don't have positive pressure, succinylcholine will break it. Now, if we do that, that becomes a bigger deal here. Or if they use longer acting muscle relaxant and they're not fully reversed, which can happen, then you have to use Sugammadex because that's too much to get neostigmine and glycopyrrolate, give the right amount. Like this, take the Sugammadex, give it, they will reverse and they will break whatever airway issues they have.
I have a question.
Yes.
When we reverse somebody with these things, we can say, like if you have to give Sugammadex.
Yes.
How long should we keep them before they are discharged home?
Don't have to change
So
anything.
you don't have to change what we've done.
But
Okay, just to make
you
sure.
guys are taking at least an hour.
Yeah,
pretty
we
much
take,
from
we keep
this.
them our
Within
regular
an hour,
standard time.
the normal medication that they got and they were not reversed will naturally would have reversed. So they're not gonna go back into whatever
Because
state they
usually
were.
at the hospital, if we gave, not Robinol, if we reversed, Versed,
The romazicon.
The
Romazicon, we keep them 2 hours, we had to keep them 2 hours. Post.
I don't think you do.
Okay.
First of all, we don't give a lot. I don't think any
Yeah,
of
we don't
these
do it a lot
issues
here,
here
but-
were Romazicon issues. They're more muscle relaxant
Yeah.
or
I just wanted to make
not
sure we're-
ideal
We're
airway
still doing the right,
airway management at the end of the case. Let me put it this way, because it's on tape. Okay, hemodynamic instability. The issue here is that most of the patients will get through phase 2 quickly with their hypertension and tachycardia and then go back and we can let them be, watch them. Once they wake up, everything calms down. If it doesn't though, we need to have a few medications here on to slow the heart rate and blood pressure, or to actually go the other way if we need it. So we will have this esmolol, and nitroglycerin, which we have, I know because we had to use it for a patient, I think, or we need to use for a patient. Ephedrine, phenylephrine, epinephrine on the opposite side. So what are we looking for? Sustained tachycardia and increased blood pressure. If it's gonna take more than 15 minutes to really wake up here and you have that, very few people in their 60s or 70s, there were heart problems, the kidney problems, and diabetes they have, will take that very well. So we need to start acting on that. Again, that should not happen here. It should have been done over there, but rarely it's done. Low saturation for too long, skin discoloration, if you start seeing that. Diaphoresis, that's an immediate sign that something is about to happen. And ideal goal would be to return to pre-op vital signs, which, you know, that's more on a theoretical than practical, but that's the idea. You can let them be for 5 to 10 minutes, wherever they want to be with the heart and the blood pressure, almost. But after that, we need to start treating them if they have not been preemptively treated in the back. The medications. We have 3 medications that we need to worry about and might need to reverse. One is the benzos, the opioids, and the muscle relaxants. For the benzos, we have Romazicon, which we rarely use because not a lot of people give a lot of Versed here. For the opioids, we have Narcan. And again, I don't think we're using a lot of Narcan except somebody is using a bunch of Demerol for kids, and that's an issue, at least initially. And muscle relaxants. For muscle relaxants, you have muscle relaxants pretty much, if you have somebody here and they look weak, first of all, if they're asleep, they're not going to tell you they're weak. They cannot follow comments, you cannot squeeze the head and lift the head. But the moment they start breathing and it's very shallow, it's almost agonal, think first, muscle relaxant weakness. I don't know if we need to have a nerve stimulator here, just to have one here to check for that, because quicker, because if you can't ask them, you don't really know how to assess that. Even if they wrote there in the chart that it's reversed and this and that, sometimes they're not. So if the muscle relaxant is the issue, reverse immediately, they'll come back quickly. Otherwise, it's going to be a prolonged effort here to get them back. But the moment it feels like they're not taking deep breath, they're shallow, they're gasping for air. Nobody should gasp for air if they're okay. If you gasp for air, it means your muscles are not working, you're just trying for it. So maybe one of the muscle relaxant twitch monitors, you can just keep it here. When somebody feels like weak and never come back, just put it on. I'll teach you what to look for when it comes, and they will give you an answer immediately, and then they're fine, that's not the issue. If they're not, we can reverse them and take it from there. Questions about that? Again, the medications that we're having here again, Narcan is for opioids, flumazenil is for benzos. They have Sagamadex that will reverse the long-acting muscle relaxant. And then neostigmine and glyco is the one that you use for the normal muscle relaxant. If you don't want to use Sagamadex, you have to put them together because neostigmine will give you bradycardia and increased secretion, so you have to use glycopyrrole for that. Physostigmine is an ideal drug for delirium. Unfortunately, it's hard to get if anybody's still manufacturing it. I checked before and it's still manufactured, but I don't know exactly how easy it is to get. But the patients that jump off the bed and act weird, ideally you don't want to give anything else to, you can stop it with more anesthetic, more benzos, more propofol or ketamine, you can lower it, but that doesn't mean you fix the problem. You just delayed it and maybe they slow down or they're going to emerge a bit over a longer period of time. Ideally you give, it's called anti-delirium actually, physostigmine, so you give that. If we can find that and it's still cheap, it was nothing, it was pretty much like water. Probably now it's not, but that will fix the problem because it crosses the blood-brain barrier, which glyco doesn't, and fixes the neurologic effects of the anesthetic. So that's a fantastic drug. We can skip over the next three and just look at the last slide, which has this graph on. Pretty much gives you a very clear idea about the delayed emergence. The problem with delayed emergence is, to me, is the most important of all. If the delayed emergence is serious, it can be because of a stroke in there. Now, I've seen a couple, they're not pretty. It can be, you can think of it, oh, they're just slow to wake up. Give them more time, give them more time. But at some point you have to start thinking, all right, it's been 45 minutes, they're still barely moving. If it's a stroke, the clock started a while back in the OR when maybe the event happened, and you have a few hours until they can declot if it's a embolic or stroke. So at some point you got to start thinking, okay, again, not often, but it could happen. What am I supposed to do here to exclude all the other causes to be? Listen, they're not waking up. It's been an hour. ER, CAT scan, if, or just directly to interventional. So this looks pretty good here. Obviously, ventilation, oxygenation, blood pressure, EKG, temperature. If there are issues there, you want to solve them through the medication we kind of talked, flumazenil, naloxone, neostigmine, Sagamadex. If that doesn't solve sugar, electrolytes, which not a lot we can do on ABG because high levels of CO2, let's say they've been hypoventilated in the OR, you put an LMA, surgery instead of being an hour to like 5 hours, and you kept the LMA and the CO2 in their brain could be 80. They will be narcotized for a while, so they can take 2-3 hours, 4 hours to even wake up here. If somehow that would be something available to us to check, you say, okay, that's what's happening. Wait a few more hours. So once you start excluding all that, and they're still out, you reverse this, you reverse that, you did that, you did this. Sugar is fine, electrolytes are fine. You immediately have to think, even if you don't want to, stroke, and go. Again, you are on a clock from the moment you think it happened, which you don't know when it happened. What kind of patients here? Mostly the sitting shoulder. The sitting shoulder of pretty much one person that does it, it's Ellender. Why? The pressure, they all want low pressures, they all want ideal conditions to operate, which I understand, it's understandable, but sometimes the pressure that you measure on the cuff is definitely not the pressure here. It's lower by at least 20 or 30. And if the patients have hypertension to start with, diabetes and other problems, chronically exposed to that low blood pressure for 2 hours or so, on somebody that already has a carotid stenosis that you might not know about it, they end up here and they seem slow to wake up to you. Now the easiest one is when they're focal. One side is weaker than the other, and things like that. All of a sudden, okay, this is a stroke, they're going. But then they're not, it's a generalized weakness. then you have to think about that after you start excluding all that. So after 10-15 minutes of playing around of slow to wake up, we need to start excluding all that and think of that. Again, it's not gonna happen often, but once in a lifetime is plenty. And again, I know that you're dealing with emergence, or phase 2 of emergence here. You guys are doing a great job. I'm gonna try on my end to, not to slow the process there, but to maybe get them to wake them up a bit quicker and bring them here to you a bit more awake. I just don't want to see so much jaw thrust here because I don't think it's right. They're not protecting their airway when you do that. They're just not. And with that comes all other things that are not doing as they should do. And then you have to do things that, not that you're not trained, because many of you have experience, you've been here, done that before, so you know, I know how to do this. But you don't have to be exposed to that too often. Questions? Cheap shots, comments?
Good job.
I think that's it.